Hello everyone, welcome back to part 3 of congenital heart disease. On the last two sections, we have discussed on the first section about introduction to congenital heart disease, and on the second part, I have discussed about the Acyanotic CHD, Acyanotic congenital heart disease, the shunt lesions, and in this section, I will going to start the obstructive lesions of congenital heart disease, that is acyanotic in type, and then I will continue about cyanotic congenital heart disease. The most common congenital heart disease that causes acyanotic heart disease, which is pressure overload or which is due to obstructive problem, is coarctation of the aorta, and constriction of the aorta occur at any point from the transverse arc to the iliac bifurcation, and coarctation of the aorta is classified into juxtaductal coarctation and the preductal coarctation, and the most common type is juxtaductal coarctation or postductal coarctation. It's responsible for more than 98%. And coarctation of aorta, as we have talked on the last section, it is more common in males than in females. Obstructive lesion, especially left side obstructive lesion, is more common in males, whereas shunt lesions are more common in females. And coarctation of aorta is common in Turner syndrome, and around 25% of those who have Turner syndrome is found to have coarctation of aorta, and it is associated with a bicuspid aortic valve in more than 70% of patients. On this image, it shows postductal coarctation or juxtaductal coarctation, coarctation just below the origin of the ductus arteriosus. So when we see the coarctation of the aorta, specifically coarctation proximal to the ductus, and in this case flow is frequently from pulmonary artery to aorta through the ductus, and cyanosis in lower half of the body as an oxygenated blade from pulmonary artery feeds the lower extremity, and oxygenated blade from the left ventricle goes to major vessels of the head and the neck, and the upper extremity or the upper part of our body become acyanotic or not cyanotic. But this is relatively rare. It is responsible for around 2% of patients, because the most common types of coarctation of aorta is postductal coarctation. So this is an image of postductal coarctation, the most common type. In this case, flow is initially from aorta to pulmonary artery or from left to right shunt. And if there is a Menger physiology, the flow reverses and it goes from pulmonary artery to aorta, or it becomes right to left shunt. And cyanosis occurs later in life, and it's more common form. What causes coarctation? So when we see cause of coarctation, there are different theories from this. Two theories are most acceptable one. The first one says it is due to decreased anterograde blood flow through the aortic valve in a fetal life. Example is bicuspid aortic valve and the VACD. And the other theory is due to abnormal extension of contractile ductal tissue into the aortic wall. When we see the pathophysiology of coarctation of aorta, blood from ascending aorta, when reaching to juxtaductal coarctation, it goes preferentially to a low pressure area such as PDA or left subclavian artery with a diminished descending aortic flow. And in a preductal coarctation of the aorta, blood flow to the descending aorta is from pulmonary artery via PDA, resulting in a differential cyanosis or pink upper body and blue lower extremity. Blood pressure is elevated in the vessels that rise proximal to the coarctation, whereas it is lower in the vessels that start distal to the coarctation. And the cause of hypertension is not only mechanical obstruction, and there is some neurohormonal or neurohumoral mechanisms that plays a role in the development of hypertension in those patients. And the coarctation of aorta results in the development of extensive collateral circulation to bypass the area of. When we see the clinical manifestation of a child with a coarctation of aorta, unless it is preductal, most patients are asymptomatic. And critical stenosis might present with respiratory distress at birth, but it's relatively rare. The rest presents later in life with leg weakness during exercise, radiofemoral delay, weak pulse in lower extremity, and upper body hypertension can develop. And normally 10 to 20 mm of mercury is higher in a lower extremity. Blood pressure is normally higher in lower extremity. So If blood pressure is relatively higher in the upper extremity compared to lower extremity, this is not normal. So we should have to think of coarctation of aorta. Systolic murmur at left sternal border at the third and the fourth intercostal space can also be heard. When we see the diagnosis, chest X-ray can show us mild cardiomegaly, but rib notching from collaterals can be seen in older children, in those greater than 8 years, because it needs time to develop collateral circulation, and after development of collateral circulation, it still needs time to cause a rib notching. And on ECG, right ventricular hypertrophy in infants and left ventricular hypertrophy in older children can be seen. And on echocardiography, it shows the site of obstruction. And as we have said, in 70% there is a bicuspid aortic valve. And there is also associated lesions such as VSD, PDA, and parachute mitral valve. In certain situations, the echocardiography can tell us those things. And also angiography better defines the anatomy. When we see complications of coarctation of aorta, heart failure, especially in neonates, infective endarteritis, subarachnoid bleeding from Berry aneurysm, mycotic aneurysm, and aortic dissection can occur. And regarding treatment, medical treatment for managing hypertension with ACE inhibitors, and if it is significant coarctation, excision of coarct and reanastomosis is important. So treatment needs surgery. The next issue is about cyanotic disease. A severely ill neonate with cardiorespiratory distress and cyanosis is a diagnostic challenge. And if congenital disease occurs, its potential life-saving measures must be instituted by early identifying it. And the differential diagnosis for ill neonate with a cardiorespiratory distress and cyanosis includes if it is weak or irregular respiration. This is associated with convulsion, depression, and a weak sucking reflex. This strongly tells us some CNS causes. Whereas cyanosis with respiratory distress and vigorous or labored respiration with tachypnea, it shows primary cardiac or pulmonary disease. To differentiate from cardiac and pulmonary disease, we need to do hypoxia test. In this case, it differentiates cardiac cause from pulmonary because the latter, that means the pulmonary improves with 100% oxygen. And percent pulmonary hypertension improves with 100% oxygen. And respiratory distress syndrome from CNS insult improve with artificial respiration. Other features that we should have to see is if there is a murmur, it is a clue for cyanotic disease. But most have no murmurs, even with a significant cyanotic CHD. And on chest X-ray, we may also see cardiomegaly, decreased pulmonary blood flow. And on echocardiography, which is the only non-invasive test to confirm the diagnosis. So we can differentiate the cause of the cyanosis and the respiratory distress first by doing a hypoxia test, and later we can also do chest X-ray and also echocardiogram. So from cyanotic congenitality, it starts from tetralogy of Fallot, because this is the most common cyanotic heart disease, and it is responsible for 5 to 9% of all CHD. And to say it off, it needs 4 components. That is malaligned ventricular septal defect, right ventricular outflow tract obstruction, right ventricular hypertrophy, dextroposition overriding aorta. That is why it is called tetra. And only ventricular septal defect and the right ventricular outflow tract obstructions are responsible for the physiology. This shows the image of a child, a heart having a tetralogy of Fallot, narrowed pulmonary artery, ventricular septal defect, hypertrophied right ventricle, and dextroposed aorta, which is overriding septal defect. There are 3 variants of tetralogy of Fallot. There are classic tetralogy of Fallot, pulmonary atresia with VSD, and tetralogy of Fallot with absent pulmonary valve syndrome. When we see conditions with similar physiology to tetralogy of Fallot, TGA, VSD, and the pulmonary stenosis, and also double outlet right ventricle with pulmonary stenosis and atrioventricular septal defect with pulmonary stenosis have similar physiology to and also sometimes single ventricle with pulmonary stenosis can have similar physiology. To see clinical manifestation of tetralogy of Fallot, cyanosis depends on the degree of pulmonary stenosis or degree of right ventricular outflow tract obstruction. And severe stenosis can cause cyanotic with distress immediately or days after birth when PDA closes. And minimal obstruction can cause acyanotic or large left right shunt, which is called pink tetralogy. Overall, they might have exertional dyspnea, hypoxia or Tate spells, growth failure, dusky blue skin, gray sclera with engorged blood vessel, marked clubbing of the fingers and the toes, and also bulged precordium can present, and also ejection systolic murmur at left second space can be heard. When we see about hypoxic spells or Tate spells, it is common during the first 2 years of life, and the mechanism is due to near total obstruction of pulmonary blood flow with hypoxia and metabolic acidosis. And onset is most of the time it is spontaneous and unpredictable, and the time of occurrence is most of the time in the morning on initial awakening and after episodes of vigorous crying. The presentation is hyperapnea and restlessness, cyanosis, which increases progressively, and the gasping respiration, and even it might cause syncope. And the duration and the severity ranges from few minutes to hours, but it's rarely fatal. Events after attack include generalized weakness and sleep, convulsion, or hemiparesis. Regarding treatment of Tate spell, we should have to put the patient on knee chest position or squatting position. This increases the systemic venous return and oxygen administration, sedation, specifically with morphine, and the volume expansion with small amount of fluid, such as 5 to 10 ml per kg, and administration of propranolol 0.1 to 0.2 mg per kg to relax the right ventricular outflow tract. Regarding diagnosis, on chest X-ray, there is narrow base of heart and uplifted apex of the heart, which gives a boot-shaped cardiac slit out, and the small size pulmonary artery and the decreased bronchovascular marking can be seen. And on ECG, right axis deviation and hypertrophy can also be seen. And echocardiography tells us the degree of overriding of aorta, degree of right ventricular outflow tract obstruction, presence of PDA, and the positioning of aortic arc, because around 20% of TOF have right-sided aortic arc. This chest X-ray is chest X-ray of a patient having tetralogy of Fallot. It shows narrow base and the uplifted apex, which gives a boot-shaped heart. Complications such as infective endarteritis, systemic embolism, and brain abscess can happen. Regarding treatment of TOF, prostaglandin infusion if severe cyanosis at birth to keep ductal patency might be needed, and phlebotomy with iron supplementation if the patient is polycythemic, and the most important thing is surgical correction of the problem. The other cyanotic disease, transposition of TGA is responsible for 5% of all congenital heart disease, and TGA is more common in infants of diabetic mothers and in males, and without corrective surgery or palliative surgery, mortality is more than 90% in the first year of life. There are two types of TGA, DTGA and LTGA. When we see DTGA, in this case, the systemic veins returns to the right atrium and the pulmonary vein to the left atrium normally, and the connection between the atria and the ventricles are normal, atrioventricular concordance, and the aorta arises from the right ventricle and the pulmonary artery from the left ventricle. In normally related great vessels, the aorta is posterior and to the right of the pulmonary artery, and in B transposition of great artery or BTJ, the aorta is anterior and to the right of the pulmonary artery. That is why it's called D, which indicates dextroposition the aorta. On pathophysiology shows there is a desaturated blood which returning from the body to the right side of the heart goes to the aorta and back to the body again, whereas oxygenated pulmonary venous blood returning to the left side of the heart is returned directly to the lung. And survival depends on shunt lesions such as PDA, VACD, ACD, or if those things are not available, palliative atrial septostomy is mandatory. This shows transposition of great vessels, the D type. And in this case, there is obligatory shunt since there are two separate circulation, because aorta arises from pulmonary infundibulum and pulmonary artery arises from the anatomic left ventricle. Regarding the diagnosis of TGA, patients present with a severe respiratory distress and the cyanosis at birth if there is no adequate mixing between the pulmonary and the systemic circulation, and immediate management with prostaglandin or atrial septostomy is needed if there is no shunt lesion. And cyanosis and heart failure is the most common presentation. And cyanosis is not responsive to oxygen. in this case. And on ECG, right side dominant leads, and on chest X-ray, cardiomegaly with narrow base with increased pulmonary blood flow or egg on the string appearance can be seen. And on echocardiography, it might confirm the diagnosis and the type of transposition can be noted, and it might assess the presence of a shunt. And catheterization for palliative atrial septostomy might be needed if there is no shunt lesion. And LTJs, in this case, it is anatomically corrected, and in this case, the systemic veins returns to the right atrium, and the pulmonary vein to the left atrium, and the left atrium is connected to the right ventricle, and the right atrium is connected to the left ventricle. In this case, there is atrioventricular discordance, and the aorta arises from the right ventricle, and the pulmonary artery from the left ventricle. So it is physiologically corrected. As you saw in this picture, corrected transposition or air transposition, there is inversion of the ventricle with transposition of the great vessels. Regarding treatment, palliative atrial septostomy for DTJ with no shunt lesion, and definitive treatment is arterial switch surgery or jetanir for DTJ, and arterial switch followed by arterial switch for LTJ. Thank you for your attention. This is all about congenital heart disease.